The GeriPal podcast is brought to you by Archstone Foundation, preparing society and meeting the needs of an aging population. And now, here are your hosts.
Welcome to the GeriPal podcast. This is Eric Quadera.
This is Alex Smith.
And Alex, who do we have with us today?
Today, we are welcoming from on the other side of the world, in the other hemisphere, Nagham Ailabouni, who is a doctor of clinical pharmacy and is a postdoctoral fellow in quality of medications and pharmacy research center at the University of Southern Australia. Welcome to the GeriPal podcast, Nagham.
Thank you very much.
And I am always excited to have a pharmacist on our podcast.
Right. We've had Lynn McPherson, we've had a few, and we've had David Currow, who is also from Southern Australia, but rarely do we have guests from so far away.
So big thanks for joining us. We're going to be talking about your recent JAGS publication, Medication Use Quality and Safety in Older Adults, a 2019 update where you talk about 4 really big articles that came out around medication use and safety. But before we do that, we always ask for a song request. Do you have a song request for Alex?
Yeah, it would be great if Alex could play Down Under for Men at Work.
And why this song? It's maybe obvious.
Yeah, since I'm in Australia. Yeah.
Right. You're down under. Tried out combat on a hippie trailhead full of zombies. I met a strange lady. She made me nervous. She took me in. She gave me breakfast. And she said, "Do you come from the land of down under, where women glow and men plunder? Can't you hear the thunder? You better run, you better take cover."
Nice. I heard it was also a big day in Australia. You have a new or updated national anthem. Is that right?
Yeah. So it seems. So it's just in time for Australia Day, which is at the end of the month. So that's exciting.
Wait, what's Australia Day? I feel like...
It's on the 26th of January, and people usually, they go out and they celebrate Australia and everything that's in it, and it's people. So it's a good day. It's usually people are very happy because it's right after the holiday season and everything. So
nice. And how are things right now with COVID? Australia and New Zealand feels like they've been doing good things.
Right. We're very lucky. We're very lucky, especially in the state in South Australia. We've managed to keep things really under control, so can't really complain too much. There's still some restrictions here and there, and some of the states are closed off in terms of borders to each other. But and I'm a Kiwi, and I couldn't travel back to New Zealand to see family, but it is what it is, and we're very lucky in comparison. So, yeah. How about you guys?
I think it's right now. What day is it today, Alex? I keep on forgetting the day. January 4th for our listeners. And we're both in California, but there's a big difference between Northern California and Southern California. Southern California is being hit pretty amazingly hard.
Yeah, pretty bad.
And Northern California is just not feeling that same level of surge. Mm-hmm. I think a lot of it has to do with, like, you walk around the city and you see people wearing masks, simple things. But we're not here to talk about COVID. We're here to talk about medications and medication safety. Would you mind just, before we talk about the paper and the articles, how did you get interested in this subject?
So I'm a pharmacist by background, and when I was practicing as a pharmacist, I usually cared for older adults, some that had dementia and some that didn't. But I noticed the overwhelmingly large number of medications that they were prescribed, and that's sort of how I got interested in this topic overall. And then I pursued my PhD at the University of Otago in Dunedin in the southern island of New Zealand. And that was around de-prescribing in older New Zealanders. And then since then, I completed a research and teaching fellowship that specialized and focused on geriatric pharmacy at the University of Washington at the Klein Center for Geriatric Pharmacy. And this review really was part of the project, one of the projects that I led during that time. And its aim was really to succinctly highlight pertinent topics that related to promoting the safe use of medications in older adults and promoting awareness about how do we best optimize medications and remove medications that might potentially have more harm than possible benefit.
Mm-hmm. So this reminds me of something that Eric and Ken lead at the American Geriatrics Society every year, and I provide musical comedy for, which is a review of articles from the past year that are sort of high-hitting. In your case, it's really focused on medication safety and quality and de-prescribing. I don't know that our listeners are going to be super interested in the methods and how you surveyed the literature and all that, so maybe we'll just skip over that.
Okay.
That sounds great.
It's a lot of work, but that's usually what happens.
Yeah. A lot of
We'll
work
leave it
went
at
in up front,
methods.
and then
It was
you
a lot
found
of work.
4 articles.
Correct. Yeah, that's the important part.
Should we talk about the first one here?
Yeah, let's talk about the first one.
So that was older Medicare beneficiaries frequently continue medications with limited benefit following hospice admission by Zuger et al.
That was in JAGS, correct? Was it?
He was in the Journal of General Internal Medicine.
Journal of General Internal Medicine. Okay.
Yeah.
Correct. So, I guess the main points about this article is that as people near the end of life, there are certain medications that could have been initiated in the beginning that were of therapeutic benefit. But as goals of care change, as diseases progress and prognosis changes, those medications may become unnecessary or they could be of limited benefit. And so what Zuger et al. Did is that they aimed to quantify the prescribing of limited benefit medications in patients who had cancer and non-cancer patients as well after hospice admission. And then they tried to look into the factors that could predict why these medications are being continued. And so what they found is that most patients, about 78.7%, used at least one limited benefit medication before hospice admission, and that remained after hospice admission in about a third of the patients. And those rates were similar between cancer patients and non-cancer patients. So perhaps, that leads us to believe that wasn't really a factor that underpinned why these medications were being continued. And what we do know is that they found that anti-dementia medications particularly were continued more frequently, whilst anti-osteoporotic medications and anti-hyperlipidemic medications such as statins were least continued post-admission. And so that's sort of a main finding that was really interesting, is that why were anti-dementia medications continued after hospice admission, particularly because given the nature of hospice admission, and Eric and Alex, you can comment more about that, is that the goals of care is more about comfort and rather than prevention for patients who perhaps have a limited life expectancy.
Yeah, I was actually I thought the numbers would be higher than a third. So that in some ways I was a little bit reassured that, hey, when people get admitted to hospice, like a significant portion of these medications were discontinued, which was reassuring. But then on the other side, like a third are still taking at least one of these medications, which is kind of worrisome. How did you think about it as a pharmacist?
Right. I mean, I think you make an excellent point, Eric, because I think a lot of the times we can be really harsh on prescribers. And what we know from de-prescribing studies in general is that, if we have a third of medications being discontinued, that's actually a really high success rate. And so it's actually pretty positive overall, but it matches research that has been found in other parts of the world, such as in England, that approximately a third of cholinesterase inhibitors and memantine are inappropriately initiated or continued for longer than appropriate in about a third of these situations. And particularly here in Australia, we know that even though we have medication reviews being conducted by pharmacists in the residential care setting as well as in hospice, these medications are still being continued in about a third of patients as well. So, it's a problem that's being found worldwide.
Right, worldwide issue. And there's no like hard and fast number. It's not that the number should be absolutely zero, because some of this depends on patient preferences and some of it depends on exact clinical circumstances. But 1/3 still seems quite high. What do you think it's going to take? At what level are the major interventions needed in order to impact de-prescribing in hospice? Because you can think of all these different levels. Is it the level of the pharmacist, which you're most familiar with? Is it the level of the hospice nurses talking with patients? Is it the level of the doctor, supervising doctor in hospice? Is it the level of patient activation around de-prescribing, or all of the above? I don't know. What are your thoughts?
Yeah, so there was a recently published systematic review in BJCP that was focused around the barriers and facilitators to de-prescribing, and that was in the primary healthcare setting, which is different, obviously, to hospice. But I think that the same barriers and challenges that face de-prescribing exist, and as you very nicely highlighted, Alex, it starts with the patient level, their own patient preferences and values, the family, the caregivers, and then it goes into the prescriber factors such as inherited prescribing, multiple prescribers, and then organizational factors such as fragmentation of healthcare. A lot of these people, they're quite vulnerable and they have increasing frailty. And frailty is a hot research topic at the moment, because how does that actually stratify how we screen for patients and better deliver, medication reviews by pharmacists or other, clinicians such as nurse practitioners to really target trying to optimize medications being used. But I think when it comes to anti-dementia medications, there's actually been a de-prescribing guideline that's been developed by my supervisor, Dr. Emily Reeve, and that work was an international collaboration between Australia and Sydney and Canada. And these de-prescribing guidelines, what we are working on at the moment is a consult patient decision aid that's focused on trying to get people with dementia, and perhaps especially in the hospice setting, to think about maybe it's time to review and discontinue the anti-dementia medications. So I think more dissemination and development of such decision aids that can be a conversation starter with the clinician is going to be really pivotal and might change things, as well as we certainly know a lot about the barriers, but we still don't know a lot about what are some of the things that we can use as strategies in clinical practice to really increase the uptake of de-prescribing guidelines in practice. And so that's something that we're working on at the moment.
All right, so for our clinicians who are listening to this, whether it be nurses or physicians or pharmacists, let's talk about some of these. Like if we're admitting somebody to hospice, what are some medications that may be of limited benefits? We're talking about dementia medications, cholinesterase inhibitors, and NMDA receptor antagonists. I think in general, they may be of limited benefit, but we have really no studies in people with hospice eligibility, advanced dementia, that they really do anything.
Or dementia is a comorbid diagnosis for people with cancer.
Yeah. So that one seems like, that's a really good place where we can start as far as stopping medication classes. What other medicines are on that list of yours?
things like statins, we still see a large number of people who are prescribed things like, aspirin. And although, there is definitely some benefit that's been demonstrated for aspirin being used for secondary prevention, certainly at that point, you might want to be thinking about taking them off that. And, there's still the bisphosphonates that have been on, and that's a large group of medications where there's increasing research that this is a good target for de-prescribing, certainly if they haven't been reviewed after the 3 to 5 year point. So those are some major medication classes that I can think of. Anticoagulants as well, that stand out, proton pump inhibitors. Maybe in some patients it could be of benefit. And I think, something that I highlighted as a limitation is that certainly we're looking at this from a data set point of view, but there could have been exceptions to the rule where it was actually appropriate to continue the medication. So, and those reasons might not have been documented. So it's really difficult. Right. And it does come down to a conversation with the patient and the caring.
Yeah, it's hard from these secondary data set analyses to know how much of this, continuing the memantine or whatever dementia medication was due to patient factors, caregiver factors, what? No, I can't stop that, and how much of it was due to the clinician de-prescribing some things but not recommending de-prescribing others.
Correct.
Yeah, I think one of the challenges that, when I was last on service and we were admitting somebody to hospice, was thinking about antihypertensives. So when is it potentially valuable to continue? What's the indication? I know antihypertensive was on the lists of limited benefit medications in this study, but if they were on it for particular ones for heart failure or for angina or for a recent MI or AFib, a flutter, that was kind of excluded in this study. I think one of the challenges we often face is for AFib, should we continue their metoprolol or should we discontinue it? Are they on the metop for because they went rapid and they needed it for rate control, and were they symptomatic from it? What are your thoughts on antihypertensives?
I think that you really hit the nail on the head there, because, antihypertensives is one of those things that we don't know if it's there for heart rate control. We don't know if it's there because of, postural hypertension. There's lots of different reasons why people, and it's usually a class of medications where you don't get one medication prescribed, from what I could see in clinical practice, right? People are often prescribed multiple, and that's actually quite interesting because it ties in with the point of the fourth article in this review, which is that often after hospital admission, these medications are intensified. So it's one of those things that I think is very difficult to develop a broad overview things, such as, for example, benzodiazepines and sleeping tablets, where we know that they're just terrible and the number needed to harm is so high in comparison to the number needed to treat. And so I think that's definitely one that really has to go back to a conversation and an individual basis rather than an overall type recommendation.
And as a geriatric pharmacist, you also must have a pet peeve medicine. Do you have a medicine where you see it in somebody who's being admitted to hospice or, has a life-limiting diagnosis that just jumps out to you?
I really think metformin. When you see really high doses of metformin being prescribed 3 times a day, I'm like, what are we doing to this patient and why? But again, I think that you guys can comment more about this, because the journey of one hospice patient in comparison to another could be completely different. And the number of months that they could be in there, could differ drastically between one patient and another. And so perhaps as well, in some circumstances, certain clinicians might have actually tried to take that patient off of the metformin and they just didn't cope with it. And so it could be appropriate because it could be easier to help manage the patient as well. So I think it's also important that as pharmacists looking at the medication list, that we don't just always jump to conclusions that, oh, this medication definitely shouldn't be there, and why is it there, and sort of, have the benefit of the doubt.
Although it's maybe it's that pharmacists should take a more active role and say to clinicians, hey, why is it there? Because metformin, for example, is designed to reduce blood sugar in people with diabetes, oral and hypoglycemic medication, and it takes about 10 years of preventive treatment with tight blood sugar control to receive benefits in terms of reduced microvascular complications like diabetic retinopathy or nephropathy. 10 years is very different from the 6-month prognosis of people in hospice, 6 months or less. So it doesn't seem to make a lot of sense. On the other hand, you could say, well, if I take them off it, then they'll run high. Maybe they'll be symptomatic. Maybe that's their reason. But usually people run high and don't get too symptomatic. So there is some accounting for individual circumstances, but certainly not high doses 3 times a day. That'd be a red flag.
So you brought up the Anderson article. So I'm going to jump to your article number 4 in this paper because you already brought it up, which is from JAMA IM. Includes folks who've been on this podcast before, including Mike Steinman, Charlie Ray, on clinical outcomes after intensifying antihypertensive medication regimes among older adults after hospital discharge. You want to just give us a little brief what happened, what they did in this study?
Sure. So, as I mentioned before, during hospitalization, intensification of older adults' antihypertensive medications could occur, and this could actually increase the risk of them developing or experiencing adverse clinical outcomes. And so what Anderson et al. Aimed to investigate is this association between the antihypertensive regimen intensification at hospital discharge and clinical health outcomes after. And so, what they found is that there was a higher risk of readmission amongst patients who received antihypertensive medication intensification, and that was not actually associated with any improved blood pressure control or reduction in cardiac events within 1 year. And in fact, it was associated with an increased risk of readmission and serious adverse events within 30 days. Which is a major finding. And this was, the strength of the study is that it was really one of the first studies to examine clinical outcomes associated with the intensification of antihypertensives at hospital discharge. And it's something that, in clinical practice, I've definitely seen it happening, but I didn't, when you're working in a hospital setting, it's very difficult to kind of see from the follow-up point of view what happens to the patient afterwards, unless they're, high flyers and they, as we call them here down under, and they always come back into hospital and get readmitted. So, I found it really interesting.
Yeah, I thought this was fascinating too. That this idea of like when people get admitted to the hospital, mucking around with medications that are supposed to reduce events over many years just because their blood pressure was slightly high in the hospital. I think it serves as a good warning that, if something takes years to develop a bad outcome, maybe the hospital isn't the best place to be moving around those medications unless their blood pressure is like 180, 200 systolic.
Yeah. I think we did an article about this. Actually, it was Tim Anderson's first study, which documented intensification of blood pressure medicines for older adults admitted to the hospital at one of the AGS reviews of the literature. And the song that went with that one was, remember, Eric? Let it go, right? Just don't do it. You're so used to, as an outpatient doctor, it's like a knee-jerk reaction. Blood pressure higher than guidelines, must treat, right? And that's what people do, but they're using outpatient guidelines in the inpatient setting. And what I like about this article is it suggests that, hey, there aren't really benefits here, and there are potentially harms that might be, still not convinced they're completely tied to the medication intensification, but certainly there are, in the setting, a few benefits and potential for adverse events. associated with intensification. This is a practice that should be stopped.
Yeah, and I think that really, from my research and my PhD, what I found is that when I would talk to primary healthcare physicians, one of the doctors I very remember clearly saying in his interview, he was like, if we could just stop hospital doctors following these crazy guidelines and prescribing all these medications when the patient goes into hospital, then we would be doing, saving them a lot of harm. Because what ends up happening is that the patient's prescribed all this medication, they go back to the GP or primary healthcare provider, and then everything stopped again, and then the same thing happens again and again. So it's a bit of a cycle. And so I think improving communication at transfer points of healthcare is really the key that I see helping with reducing this phenomenon from happening.
Okay, I got the third paper that I'm going to bring up is kind of the opposite. There's a lot of discussion around stopping medications that may be inappropriate, but thinking also about starting them. And is there a role for using like the emergency room as a place to think about what medication should people be on? So the next paper was oral anticoagulants prescribed in the ED and long-term use. You want to describe that article real briefly?
Sure. So, underuse of medications is definitely another aspect of suboptimal prescribing and is just as harmful. And we know that there are criteria such as, the START criteria that focus on medications that could have been helpful but are omitted. And so this is a really good paper that highlights that as an example. They found that out of the 2,000 or so older adults that met the inclusion criteria, 18.9% were given a prescription for an oral anticoagulant in the ED. And then what they found is that a higher percentage of those patients who received a prescription in the ED for an oral anticoagulant and were alive at 6 months filled a prescription for an oral anticoagulant in comparison to those who did not receive a prescription for an oral anticoagulant. So what we found is that, 71.8% of the patients received such as an ED prescription had higher chances of continuing that medication that actually reduces the risk of future strokes and heart attacks. And so what this paper sort of suggests, and the authors, is that perhaps this idea of ED physicians prescribing bridging therapy so that they just have, default short-term anticoagulants that would bridge the patient over until they're discharged and then suggest a follow-up with their GP to discontinue that if they no longer need it might be an approach.
Right. So people come into the emergency department with new onset atrial fibrillation. They're more likely to continue on anticoag or be prescribed and fill and continue on anticoagulants if they're prescribed in the emergency department than if they're left to the primary care practitioner or general practitioner, as you say, in Australia and Canada and the UK and most of the rest of the world. So emergency providers should be doing this. It seems like a very reasonable in order to prevent stroke, which is a terrible outcome for older adults. I guess you could argue, well, maybe there was something different about those patients who they deferred to the primary care clinician, but it looks like they did a nice job in this terrific data set. They have wonderful data sets in Canada of accounting for those potentially confounding factors.
Yeah. And I mean, there's always going to be other confounding factors because that's just the nature of this type of research. But I think overall what it shows is that typically these medications are not being prescribed in the ED. And this is an important consideration that could actually potentially save a lot of, grief later on in terms of adverse drug events that could happen later on in readmission. So,
and then how do you think about this article versus the last one? The last one we were talking about, like, hey, don't muck around with the antihypertensives if they're admitted to the hospital. Maybe let the primary care provider muck around with it. once they're out of the hospital, once you see kind of what their blood pressure is when they're not getting poked and prodded, when they're not in pain, versus this one, we're kind of saying, hey, we should be using the emergency room. We should be discharging people on anticoagulants, and then let the primary care provider kind of figure out what to do. How do you think about those? Are those opposites in your head, opposite decisions, or how are you thinking about it?
Yeah, I mean, I think that what's interesting is that now as we're promoting, awareness about potentially inappropriate medications, that's a real concern. But I think that when there's an indication, medications, and there is therapeutic benefit, that we want to be encouraging people to prescribe them. And certainly in the case of atrial fibrillation or, somebody that has had a DVT, I mean, those are definite indications for starting an anticoagulant, and those things should be taken into consideration, and people shouldn't be wary or scared of doing that, because later on, if they can definitely guarantee that the patient's going to have an outpatient follow-up appointment, and that's something perhaps the job for a pharmacist to, once these prescriptions in the ED are being handed out, that a pharmacist goes. And I remember as a pharmacist in New Zealand, that was a big part of my role, is to go and talk to any patient that has had a new prescription of an anticoagulant. And we actually used to follow up with them a week after their hospital discharge, just to make sure that they're okay, and that, if it was meant to be stopped after 10 days, that they have actually stopped jabbing themselves with it, and et cetera, et cetera. And I mean, I guess that's a difference, because this paper focuses on warfarin. And so a comment that we had included is that it could be different given these more contemporary oral anticoagulants such as rivaroxaban that are more commonly used now.
Mm-hmm. It's good that you're just talking about your own clinical work and interventions, and this is a nice link to the 3 studies we've talked about so far. Have all been observational studies. We're talking about how you have potential for confounding is higher in observational studies. But the last study is a trial, right? This published in JAMA Network Open, the effect of an electronic medical reconciliation intervention on adverse drug events, a cluster randomized trial by Tamblin et al. Do you want us to tell us about this? What is electronic medication reconciliation?
Right. So they developed this tool that's the right prescription, or right RX, which is really difficult to say. It's quite a tongue twister. But what it allowed, or their intervention really focused on retrieval of community drugs that were issued from the provincial insurer. And then the intervention involved reconciling that with the in-hospital drugs. And in addition to that reconciliation, it also allowed linkage with the names and the addresses of the community-based physicians and pharmacies, so that there was more communication about drug changes after discharge. And so it wasn't just a comparison per se, but there was also that communication aspect as well. And then they assessed outcomes after 30 days following hospital discharge. Now, they didn't actually find a difference in the ED visits or hospital readmissions, but between the intervention and the control group. But overall, there were less medication discrepancies in the intervention group in comparison to the control group.
Mm-hmm. So the meds were more similar in the intervention group to what they were supposed to be in the intervention group, but the outcomes that sort of harder outcomes, I guess you could say, didn't really budge. What do you think happened there?
So I think that there are factors that we don't yet know about that's at play, and it could be explained partly by the fact that medication discrepancies may not be related to adverse drug event occurrence. Just because there are differences in the medications, both lists could be wrong. Like the medications in both circumstances might not be optimal for the safety of the person.
All right, that's a good point.
Yeah. And so I think that it reaffirms, though, that if there were the group of patients or the part of the population that are having these multiple medication changes, they're definitely susceptible to be at a higher risk of developing adverse drug events. And that's the one thing that we could take away from this paper. But there should be additional strategies to try and mitigate the risk. And I think medication reconciliation from the perspective of pharmacist, it's great. That's one of our core roles in pharmacy, in a hospital setting particularly. But it's sort of, I see it as a first step. And it's not really taking it that step further and thinking about, the appropriateness of the medication. And that's what we call a medication therapy assessment in this part of the world. It's thinking about taking the time to really nut it out, take apart the medication list and ask questions about why is this prescribed? How long had they had it for? And I think without that happening, we're not going to be able to really see a major change in adverse drug events. And even then, we need large numbers in these gold standard RCTs to also show that.
Right.
I feel like if you ask most clinicians about medication reconciliation, their heart rate will increase. They will have, their eyes will narrow. They'll have a mean face because we've all been forced to do medication reconciliation, but not in like a good way. It's you have this list of medicines, you have another list. They're like, it's a very bureaucratic form that most of us have to fill out that really does absolutely nothing for the patient, but it's like a documentation that it occurred. And it makes people really probably despise the concept of medication reconciliation rather than thinking of it as a really helpful tool. Is a part that we just don't have a tool yet that actually works for medication reconciliation. I haven't seen RightRx, but it made me think, maybe it was the tool.
Yeah, I think so. I think you really, that's a really good point. And that same reaction that, clinicians have of, the sweat rolling off their forehead happens when they see a pharmacist going up to them to talk to them. It's like, oh, I did something wrong, with my med rec or whatever. I think that there has been something that's an online decision support thing that's been developed called GMEDS, and that sort of really tries to highlight the high risk drugs, which are the drug burden index drugs. Those are medications that have an anticholinergic or sedative property, and it works its way through to reconciling them and then thinking about, should they still be on them? And then it's more of a communication tool as well. And I think that's something that we really need more of. And we need to understand how to better implement such implementation strategies more effectively, both in research studies as well as clinical practice.
What's next for you in your research?
Yeah, so I'm very interested in improving the knowledge translation of de-prescribing in clinical practice, and that's sort of the focus of my fellowship research proposal. So I'm currently trying to develop a tool that helps older adults initiate conversations about de-prescribing with their provider. Because we do have some questionnaires that have been trying to gauge, how willing people are to de-prescribe their medications. Because usually, we know that some patients can be very attached to their medications, especially that, we've told them to take them for donkey's years. And then they're like, you tell them as a clinician or as a healthcare professional, you don't need to take this anymore. And then they're like, what do you mean? I've been doing this for 20 years. So it's kind of flipping it around and trying to have this paradigm shift where we, activate patients to have more self-efficacy and empower them to ask questions about their medications, and then hopefully that can sort of lead the medication lists to be more aligned with the patient preferences. So that's sort of what I'm working on at the moment.
That's terrific work. Well, we're so happy that you did this study and that you published it in JAGS, and that you're continuing in this vein, because we need work at all levels, at the pharmacist level, as we talked about, the clinician level. Patient activation is some of the stuff you're working on. It's not going to be one intervention or the other that really does it. It's going to be all of the above. Right.
Thank you very much. No, it's great to be here.
Yeah, big thank you for joining us today. But Alex, can you hear that? Can you hear that thunder?
I thought you were going to make a Vegemite joke.
I was thinking about Vegemite. Should I go for Vegemite? You speaking my language, or?
Okay, I have to admit, I Googled a few of the words in here, like combi. I don't know what that, I guess it's some sort of witchcraft or something. And then chunder. I guess is vomit.
I don't even know.
This song is just so silly. It's so ridiculous if you think about the words. But here's a little bit more. Buying bread from a man in Brussels. He was 6'4" and full of muscles. I said, "Do you speak my language, brother?" He just smiled and gave me a Vegemite sandwich. And he said, "I come from the land of down under, where beer does flow and men chunder, and women too. Can't you hear the thunder? You better run, you better take cover."
You like Vegemite?
Nah, I'm not one of those Australasians. Not, yeah. And even in New Zealand, it's Marmite, and it's just as bad in my eyes. I'm sorry.
Stuff is gross. I have a friend who's British growing up. He used to just try to get me to eat that at every sleepover. It's just,
did it work?
Vomit. No, couldn't stand it.
People that love it, they're just like, you just need to put butter on it. Just butter it up, and like, still just as bad.
You can't cover it up. You need to de-prescribe.
De-prescribe the Vegemite, the Marmite. Well, a very big thank you for joining us today. It was really a pleasure having you, and really encourage all of our listeners to check out the JAGS article that was published on this. We'll have a link on our website. Any other plugs that you want to do for de-prescribing websites?
Yeah, so there's de-prescribing.org. That's a great one. And then we also have an Australian De-prescribing Network website that's currently under construction, but that's also something to check out. But we're very active on Twitter, so check us out there.
And there's the U.S. De-prescribing Network, which Mike Steinman runs. We invited him to be on the podcast. He was unfortunately unable to join due to clinical responsibilities, but we'll have him on in a future date to talk about this issue some more.
And again, big thank you to all of our listeners for joining us and supporting the Jerry Pal podcast. And thank you, Archstone Foundation, for your continued support. Good night, everybody.
Good night.